All right, let's get started. So yeah, we've got an exciting presentation today. We've got Alborz here from Circle Cardiovascular Imaging, which are they're in Calgary, so a nice local presenter. He's the lead machine learning software engineer at Circle, and he has a PhD in bioengineering from UBC, and has done a ton of different machine learning and image processing work. Specifically in many areas, and obviously the cardiac area. And so, yeah, I'm interested in and excited to have you as a presenter, and look forward to your presentation. Thanks, Alberta.
Thank you, Jesse. Appreciate the introduction. Allow me to share my screen super quickly. Okay, there we go. Can you see my screen? Excellent.
Yeah, looks great.
Perfect. So, yes, as Jesse said, my name is Alborz, and I lead the cardiac AI team at Circle Cardiovascular Imaging. And today I will be talking about how AI can help cardiac imaging and share a couple of examples of how we have recently used deep learning solutions specifically to improve the workflow of our software tool. But before talking about the role of AI in cardiac imaging, and specifically how we're using AI, I will spend a few moments to just talk about who we are. Circle Cardiovascular Imaging is a software development company that is indeed based in Calgary and was founded back in 2007. And our vision is to transform the future of cardiovascular imaging solutions. Our software is actually used in more than 1,000 sites in over 50 different countries around the world. And we have more than 150 employees that are based in 15 different countries. Most of us are actually based in Calgary. And before getting into the nitty-gritty of AI and cardiac imaging, it's important to know why cardiac imaging is important when it comes to diagnosing cardiovascular diseases. There are many structures inside the heart, as you can see here. The anatomy of the heart is very complex and dynamic. There's the right atrium, the left atrium, the left ventricle, the right ventricle. And then you have all the different valves. You have the tricuspid valve, the pulmonary valve, the aortic valve, the mitral valve, and all of the great vessels, the pulmonary artery, the aorta, pulmonary veins, and the superior and inferior vena cava. And typically, when a patient walks into a cardiologist's office, normally the cardiologist starts with a clinical assessment, talking to the patient to see what's going wrong, and to essentially investigate if the problems that they're experiencing is related to a specific physical activity, for example. But sometimes it is not clear why the patient is unwell. It's really hard to tell exactly what part of the heart is causing these problems for the patient. So whether it manifests itself in terms of shortness of breath, chest pains, or just general feeling of tiredness, or etc. So it is very important to get the right diagnosis to be able to prescribe the right treatment to the patient. So to do this, cardiologists typically employ multiple different tests, which include medical imaging modalities. So for example, they might do an echocardiogram, which uses ultrasound waves for continuous monitoring of the heart chambers and visualizations of blood flow. However, if this is not sufficient, if they suspect that there could be another problem with the patient, for example, coronary artery disease, they might decide to do a CT angiogram. And CT angiogram is important to note that it uses X-ray radiation as a source of imaging, and this is potentially harmful to the patient. But due to the high resolution of CT imaging, we're able to visualize small structures such as the coronary arteries, and to be able to assess if there's a blockage happening in these important arteries, and be able to see if there's a potential problem there. Another imaging technique that is used, it's nuclear imaging, and this type of imaging uses small amounts of radioactive material for diagnosis, and it's useful for visualizing problems that may be happening in musculature surrounding the walls of the heart. And finally, there's CMR. Cardiac magnetic resonance imaging is relatively expensive and not widely available because it requires a lot of expertise to acquire and also to assess by the physicians. Therefore, it's often considered to be the last resort by the cardiologist, but it is added to the clinical routine more and more often recently. And that is because MR imaging has considerable benefits. For example, MR imaging uses magnetic fields and radio frequency waves for imaging, therefore it is safe. And its physics allows imaging of different properties, such as tissue properties, visualization of temporal dynamics, which can be used to look at how the structure of the heart is deforming. It can also be used to visualize flow, muscle fibers, and other things. Our software suite is actually designed to encompass both CT and CMR images. However, our bread and butter is CMR post-processing. So to keep this talk within the 1 hour limit, I'm going to be focusing more on how we use AI in the context of CMR image processing. So let's talk a little bit more about what we can do with CMR. As I mentioned, CMR is expensive, but it provides a lot of information to the cardiologist. It is essentially one test that can give many answers about the state of the patient. And despite its cost, it's a very efficient way to investigate the cardiovascular system. It facilitates the job of the cardiologist considerably, as the single test can tell you things, for example, about how the heart is functioning. By looking at the temporal mechanics of the heart, we can, measure biomarkers such as ejection fraction to assess the capability of the heart in ejecting blood, and to be able to visualize, possible abnormalities that are caused in the motion of the ventricular walls. Furthermore, with the help of contrast agents, we can look and see how much blood is being absorbed by different regions of the heart, and we can use contrast such as gadolinium to detect infarctions, to see if there's parts of the tissue that are dead. And in addition to using static image analysis techniques to look at myocardial infarction, we can actually observe how the musculature around the heart is absorbing these contrast agents as they're being injected using perfusion imaging to be able to detect if coronary artery disease is actually affecting how the myocardial walls are absorbing blood from the coronary arteries. And finally, we can also use MR imaging to analyze flow in the great vessels of the heart and essentially look to see if there are anomalous patterns in how the blood is flowing through the different vessels. So far we talked about the importance of CMR in cardiac imaging. Now I want to talk about the role of AI in cardiac MRI. AI can help automate the whole process of going from image acquisition all the way to the report. And we can use artificial intelligence and deep learning techniques to essentially automate a lot of the tedious tasks that the clinician needs to do. And we can actually use AI to reduce the cost of CMR studies by facilitating image acquisition. So I will first start with how we use AI, how we could use AI for image acquisition, and then I will later on show how we can use it at different stages of the workflow to go directly from image acquisition all the way down to the report. So let's start with image acquisition. To understand how deep learning can help with MR image reconstruction, we need to know how MR images are actually being acquired. So common imaging techniques similar to digital photography always have a source of energy. For digital photography, it's the sun. But another example is CT. Its source is X-ray, which is also an electromagnetic wave with a frequency that just happens to be larger than the visible light. Then, in addition to this light source, we typically have an object that we want to image and a screen or a sensor that is capturing reflections or refractions from the source of energy that bounce off this object. Physics of MRI is completely different, however, and we will probably need multiple sessions to talk about the physics of MRI. But I want to focus on one important part right now, and that is to understand how the signal of an MRI scanner is being collected. And this signal that is being collected is actually not in the image space the way it is done for digital photography or X-ray imaging. The information is in a frequency space that in the context of MRI we call the K-space. And it is also important to note that this K-space information is not acquired in a single shot. It's actually very similar to how some digital cameras record images, is that they record it row by row. And the way this is being collected, it requires a lot of time. Thus, the patient needs to be inside the scanner for quite a long time while this whole K-space is reconstructed one line at a time. And in order to go from the K-space to an image, we apply a mathematical transform, which many of you might know is called the inverse Fourier transform. And once we apply that transform to the frequency space, we have reconstructed an image. Now, one other thing I would like you guys to note is that there's a specific type of sparsity in this K-space. As you can see, most of the information is located at the center of this K-space, meaning that a lot of the information that's scattered closer to the edges are not really that useful. They don't contain that much information. So one idea would be to not collect that data, to essentially undersample this K-space, to only record samples from regions where we know contain the most amount of information. However, if we were to just blindly take certain rows of K-space and try to reconstruct it that way, we end up inducing these types of artifacts inside the reconstructed image. And this is typical of any kind of frequency space sampling, which some of you image processing experts may be familiar with. However, there's quite a lot of techniques that aim to improve this reconstruction by using compressed sensing methods and even recently machine learning based reconstruction methods to be able to speed up the acquisition. So if we're able to reconstruct the image with good fidelity using only 25% of the original K-space information, then we can speed up the processing by a factor of 4, at least speed up the acquisition by a factor of 4, right? And recently, deep learning architectures have been proposed to go directly from these low undersampled K-space data all the way back up to the high resolution images using neural networks. And here in this work presented by Daniel Reutert's team from Imperial College London, they have used an architecture that's very well known in the medical imaging community called the UNet. And this architecture is a fully convolutional neural network composed of convolutional layers with ReLU activation layers and max pooling to bring the image down to lower spatial frequencies. And then this image is reconstructed using transpose convolutions and skip connections to retain some parts of the high frequency information that tends to be lost when we downsample the image. So this is very similar to an autoencoder. However, the input and the output are not the same. The input is a undersampled K-space data, and the output tends to be the original. Sorry, I'm getting a lot of feedback through the microphone. Oh, thank you. Much better.
I just fixed that.
Thanks, Jesse. So yes, as I was saying, the input to these neural networks are the undersampled images, and the outputs are expected to be the full resolution images. And in this publication, they showed great success with using neural networks to do this. And the advantage of using AI and neural networks compared to traditional compressed sensing techniques is that these methods tend to be much faster compared to traditional methods. And they have shown to be also quite accurate. Now, another thing to note is that to go a bit further, we don't necessarily have to apply these methods to just static images, right? Typically, when we acquire MR sequences, we're interested in acquiring videos, right? We want to capture the temporal mechanics of how the heart works. So we don't just have one image to reconstruct. We have multiple images. And one thing that's true of all video sequences is that there's quite a lot of redundancy in these sequences. If I can go back to this slide and play the video again, you can see that like there's a lot of places where the tissue is static and it's not moving, and even in the parts that are moving, they're more or less the same structure, right? It's not like the video is changing much. So there's a lot of sparsity there. There's a lot of redundant information when we're looking at a sequence as a whole. So when we want to reconstruct from the whole video, maybe we can, reduce the downsampling further. Instead of, throwing out 25% of the case-based information, perhaps we can throw out more. And indeed, as you can see in this example, we can actually do a very good job of reconstructing the video using convolutional neural networks by even downsampling the case-base 6 times, right? So here we're only acquiring 1/6 of the information that we typically do, and you can see visually the images look quite bad, but there's enough information in the underlying case base to be able to reconstruct the MR image with quite high fidelity using convolutional neural networks. And these techniques are gaining in popularity currently, and rightly so, because using methods like this, we can reduce scan times and be able to capture more images to be able to improve the diagnoses that the cardiologist perform on the patient. Now, a downside to reducing acquisition time is that we tend to get a lot of images. So with a typical, well, not even a typical, with a full CMR scan, you can appreciate that there's going to be multiple series acquired, and in some cases we have hundreds or even thousands of images that are acquired for one patient. And for a cardiologist to be able to assess all of these pictures, they need to understand what each of them are, and it becomes quite tedious for them to go through all the different series that are acquired during one study to be able to understand what each one does, why they were acquired, and what they're going to be used for. So in this context, we would need image classification to be able to label these images and categorize them based on what purpose they serve, right? So one particular aspect I would like to focus on is classification of the different orientations that are acquired. Now, unlike CT scans, which can acquire an entire volume, CMR, even with compressed sensing techniques, it still takes quite a long time to acquire. So rather than capturing a 4-dimensional volume representing the deformation of the heart, the MR technicians aim to only record several perpendicular oblique views of the heart. So these are like 2-dimensional videos acquired at different orientations. So if we look at the heart image that we have, illustration that we have in the center, the chamber that the slice that really captures this view is called the long axis 4-chamber view. It is called the 4-chamber view because in this view you can actually see the 2 atria and the 2 ventricles, all the 4 chambers of the heart. And in addition to this view, they also acquired different long axis views. For example, the 2-chamber long axis view, which slices the heart through the left atrium and the left ventricle. And if you can imagine, this is essentially perpendicular to this slice of the heart. And then it gives you more information about how the mitral valve may be moving across this plane. And in addition to these long axis views, there's another orientation that's very important, and that's called the short axis orientation. The short axis orientation in three-dimensional orientation, you can picture it as it's a plane that's perpendicular to both of these. And the purpose of this is to slice the left and right ventricles along the short axis of the heart. So you can think of it as like the horizontal axis, right? So if the left ventricle is a cone-like shape, when we slice it this way, the left ventricle would look like a circle if we slice it there. And you can see the left ventricle right there. This particular view is extremely important because the cardiologists use this view to be able to measure the volume of the left ventricle. And to be able to measure the volume, they typically acquire more than one short axis slice. So it is typical to acquire 8 to 10 different slices that essentially go down from the base of the heart, which is where the valves are, all the way to the apex, where the cone just narrows down. So we have multiple short axis views, and we have different long axis orientations, such as the 4-chamber, 2-chamber, and there are also additional views, such as the 3-chamber view, which shows the aortic valve and the mitral valve on the same plane, and there's also the LVOT, the left ventricle outflow tract, which focuses more on the aortic valve. And all of these views are important for assessing the function of the heart, different functions of the heart, but the fact remains that we need to be able to tell automatically which view is being captured in each image. Now, one way to do this is to ask the technician to encode information about which orientation they're imaging into the header information of the image. So typically, medical images are encapsulated in this format called the DICOM format, which allows different manufacturers, vendors of medical images to add this metadata to the image. However, this relies heavily on the technician to be able to, add that information correctly. And it's also dependent on the vendors, the name changes, it's all encoded inside this particular tag called sequence info. And, depending on the regional language or, whether or not the technician remembers to do this, this particular header information is not always reliable, right? So one way to reliably categorize these images is to train a neural network to do it. And here we can train a very simple classification network, fully convolutional classification network, which takes images as input and tries to predict the different classes, indicating which orientation or sequence type this image is. And we have trained such a network on a large data set that is publicly available called the UK Biobank data set, which contains thousands of studies. And after training this network, we've actually been very successful at predicting the orientation, achieving about 99% accuracy with all these 5 different orientations that are shown here. And now, having addressed this need, we have gone from image acquisition to being able to classify these images and organize them in a way that's meaningful to the clinicians. Now, when a clinician opens a study, we can automatically tell them which image is which and essentially what they should be used for, right? And the next step then is to take these classified images and apply the appropriate processing to them, right? So as I mentioned before, we have different types of images. We have perfusion images and we have function images, which the function images are divided into the short axis, long axis views and so on. And in order to be able to extract the correct biomarkers, each image needs to be subject to different types of processing. For example, let's focus on function. In order to be able to analyze the function of the heart, we need to start delineating different structures inside these function images. So before talking about image processing techniques that we have to apply to these function images, I would like to talk a little bit about the biomarkers that we want to extract from these. So let's start with that one. One very important biomarker that indicates the risk of heart failure is called the ejection fraction. And what the ejection fraction measures is that it measures the fraction of the blood that is ejected from the heart in one cardiac cycle. Now, as I mentioned before, these MR sequences that we're capturing are videos which record one cycle of the heart, so essentially one heartbeat. And within these videos, we typically tend to have 20 to 50 different phases, so different frames, right? And within this cycle, there are 2 frames that are extremely important. These frames or phases are called the end diastolic phase and the end systolic phase. And they essentially capture the state of the ventricles when they're most relaxed in the end systolic phase, meaning that at this state, the muscles are relaxed and the cavity, which is formed by the left ventricle, is at its largest, right? So there's the maximum amount of blood in the left ventricle at this point. And the other phase that's of importance to us is the end systolic phase. This is where the muscles are at its most contracted state, meaning that the volume inside the left ventricle is at its smallest and all the blood has been pushed directly into the aorta. So by measuring the volume at the end diastolic phase and end systolic phase and looking at the difference of volume between these two, we can easily measure the ejection fraction. So how do we measure volume? Is rather simple. As I mentioned before, we do have these short axis slices that are acquired perpendicular to the long axis views. What you're looking at here are essentially 5 different slices of short axis acquisitions acquired for this particular image. Typically we collect about 8 to 10 different short axis slices, but here you're seeing only 5 of them. And we do this, and you can see it at both the end diastolic phase and also here on the end systolic phase. And you can see here at the end diastolic phase, the area in the middle where the blood pool of the left ventricle is larger compared to what it is in the end systolic phase. Now, some of you may notice that there's one image missing in the end systolic phase, and that's because when the heart muscles are contracting, it not only narrows in this direction, but it also shrinks, right, in the long axis direction. So we typically have fewer slices to annotate in the short axis view, in the end systolic phase compared to the end diastolic phase. And the way we go about extracting volume information from these slices is that the clinician goes through all of these slices manually, contours them, and then we use information that we have at hand, such as the thickness of each slices, to simply do an integration. So we calculate the area in each image, multiply it by the thickness of that slice, and then sum it up to get a good approximation of what the volume is at this phase. Now, what I would like to show you guys is a video of the manual workflow for doing this. As you can see here, the clinician has loaded a short axis stack into our short 3D module. The clinician is playing through the video, and what they're essentially looking for here is to be able to identify the end systolic phase, and it seems like, yeah, they're looking for it right now, and they notice that this is the exact phase where the area of the left ventricle is at its smallest. And once they have identified this phase, they start manually contouring the endocardium, so the blood pool, using these manual freehand contour drawing methods. And once they've done it for this slice, they go to the next slice, and here you see them using a different semi-automatic tool for contouring it. It's a region growing technique that they're using to expedite the contouring process. And they're going all the way from the base, so the top where the valves are, to the apex of the heart where the cone just narrows down. So one thing to note here is as the clinician is drawing these contours, the volumes are automatically updated. And once they're finished with contouring the endocardium or the blood pool, they start contouring the outer wall of the left ventricle, which is the epicardium. And this is also important because another clinical biomarker that they're interested in is the myocardial mass. So essentially the mass of the left ventricular muscle. And they're using a different semi-automatic contouring technique that uses splines to contour this. And you can see that this takes quite a lot of time. So I'm just going to fast forward a bit in this video. Ooh, that laser pointer is good, right? Yeah, this is a long video. And here you can see that they're finished contouring the end systolic phase. So what they then do is identify the end diastolic phase and repeat the entire process all over again. So if we have 10 different slices for 2 phases, you can imagine that they have to do this for 20 different images manually. And they're still going at it. 4 minutes in, 5 minutes in, they're still contouring manually. And once they're done with the LV endo and epi contours, they start contouring the RV to be able to assess the function of the right ventricle as well. And you can see here that all of these important biomarkers are measured here. For example, ejection fraction is also captured there. And yeah, they continue doing this. And once they're done segmenting the right ventricle on both phases, they're complete. So it takes about 10 minutes to do this manually. That's a lot of circles that they have to draw. So one easy way for us to, simplify this workflow is to use machine learning to automatically detect these contours that the clinicians have to draw manually. And to do this, we can use the unit architecture again, except the inputs at this point will be the raw images, the raw MR acquisitions, and the outputs are trained to be different label masks. So for example, in this label mask, 0 indicates background, 1 indicates the blood pool region, 2 indicates the left ventricle myocardium, and 3 indicates the right ventricle in blood pool or endocardium. And we have in fact trained neural networks that do this automatically. And our data was trained on, a very large data set, part of which came from the UK Biobank data set and other parts that we, have acquired through years of collaborating with different cardiovascular imaging centers around the world. And we actually assessed the performance of our machine learning algorithms compared to expert clinicians just to see how close we were in terms of matching human expert level performance. And in assessing our neural networks or our performances in contouring, we used 2 different categories of performance metrics. One, which many of you may be familiar with, is called the DICE index. It's a geometrical measure which measures overlap of predicted and ground truth contours. And we also assessed how good our algorithms were in predicting biomarkers such as in diastolic volume, in systolic volume, ejection fraction, stroke volume, and other numbers such as that. So we compared our algorithm to 3 expert raters. And here what you're looking at is the inter-observer DICE in terms of the DICE accuracy, the overlap of different structures inside the image. So here we're looking at the diastolic phase, we are looking at DICE values for the left ventricle endocardium, left ventricle epicardium, the myocardium, which is that thin ring, and the RV endocardium. And what you're seeing here in these box plots is the variation between our 3 different raters. And the X indicates the performance of our network. Well, of course, our network is consistent and there's no variation. That's why there's no box plot indicating what the variance of our network is. But what you will notice is that our algorithm is quite close to the clinician's performance when it comes to predicting the contours for LV endo, LV epi myocardium, and RV endo. We're indeed within the range of variation, and we're also very close to the median value, median score of the 3 raters that we've had. And also you can see for the same thing is observable for the end systolic phase as well. As I mentioned before, we also measured our performance in terms of clinical measures, compared on 1,000 images our performance compared to manual contouring techniques. And we saw that there was no statistical difference between our algorithms trying to estimate ejection fraction compared to manual estimation techniques. So where we're at right now is we have managed to start with image acquisition, classified it automatically, apply the correct processing, and we can go now directly to the reporting. Now, there's quite a lot of applications of artificial intelligence on reporting, and different ways we can, aggregate these reports, extract, even more data-driven biomarkers from, the known biomarkers that we have. And there's so much potential to be able to do prognosis on the state of the patient and things like that. But that honestly deserves its own 1-hour session, and I'm not going to get into that right now. Instead, I'm going to just show you a picture of what our report looks like, and it essentially captures the LV and diastolic volume, the LV and systolic volume, the ejection fraction that we mentioned, and you can see it shows the current ejection fraction in addition to the normal range that is expected for this particular patient. We have all of the patient's information. Don't worry, this is not a real patient, as you can tell by the name. And we also have other metrics that actually show regional differences rather than this global measure such as ejection fraction. We can see different parts of the heart, essentially if there are any wall motion abnormalities or something like that. And in case you're curious, this bullseye looking map is actually a representation of the 3D, the left ventricle. Essentially, if you look at it from the top-down view and flatten it, the cone would essentially be broken down to these different segments, and each segment indicates, a certain coronary territory or a region of interest. And by observing it here, we can summarize the 3D deformations that are happening inside the left ventricular muscles in this simple 2D static visualization. And this is essentially what follows all of the biomarker extraction that we do. So finally, I would like to end with this video where I show, what the process, our software is capable to do with all of the AI tools in place. So you're looking at the workflow using AI tools here, starting from the image loading. So the studies are being loaded and being transferred from the server to the client. The clinician then goes and opens the short 3D module and clicks one single button. As you can see, all the correct images have already been loaded into the module. And after clicking this single button and waiting about 10, 12 seconds, the report is already generated. It's done. And what the clinician then needs to do is go and look at the contour systolic phase and check the quality to see if everything is okay and if there's been any mistakes or any changes that need to be made on the contours. And after that, they go and double check the end diastolic phase. And within 50, 57 seconds, they're done. There's not much else that needs to be done here. And we can also automate this further. We don't necessarily have to wait for the clinician to go and initiate the contouring, right? With the recent features that we've built into our software, all of this processing can actually be done on the server side, such that if the clinician's institution has the processing capabilities to be able to do all of this classification and segmentation on their server side, when they can have it set up in such a way that when the clinician opens the study, all the contours are ready and it takes them directly to the report. Now, everyone is here to hear about AI in medical imaging, and I bet most of you are curious about the challenges that we face, not just the success stories and cool features that we put into our software. So when it comes to challenges, I think we can all agree that the biggest challenge in developing such AI techniques in the context of medical imaging is, of course, data. And what you're seeing here is the huge discrepancy that exists in publicly available databases for training such algorithms. If we compare to computer vision tasks that are trained for natural images, we have publicly available databases such as ImageNet that contains 14 million different images of cats and dogs, right? Or more than cats and dogs. I mean, there are 1,000 different classes. And of course, you have other data sets such as CoP, CFAR that have, tens and hundreds of thousands of images. In contrast, publicly available MRI data sets have at best thousands of cases. And at worst, like tens, or there's just a handful, right? And the main reason for this limitation in data is purely because, medical images are expensive to acquire, right? And there are always, ethical concerns that need to be taken into account when it comes to sharing these data. And the other problem is that even if you're lucky enough to get, let's say, a data set from UK Biobank, which contains 5,000 different studies, or actually 5,000 different images, you run the risk of not getting a representative sample of all the MRI images that are out there. So UK Biobank is actually a very good resource for these types of images that can be used for machine learning. However, one big limitation with their data set is that they're using a single manufacturer. So all of their MR scans are collected with Siemens scanners, right? And there's going to be slight differences between different manufacturers. So if you only train on a single manufacturer, you run the risk of overfitting to that particular one. And then when you try to apply your images to, sequences that were captured with, like, let's say, a GE or a Toshiba machine, there's no guarantee that, like, your algorithm will generalize well to those ones as well. Furthermore, there's also differences in magnetic field strength. So different manufacturers have different, every manufacturer has different magnetic field strengths, right? There's 1.5 Tesla MRs and there's 3 Tesla MRs, and those different acquisition parameters cause, different types of artifacts in the image. So you also run the risk of, overfitting and not generalizing to all the different types of magnetic field strengths. On top of magnetic field strengths, you have variations in patient anatomy. There's pathology cases. Most of the UK Biobank cases are healthy volunteers, right? So they're like general public, right? So you don't necessarily have representative information on people who have hypertrophic cardiomyopathy, for example, or like other types of diseases that changes the shape of the ventricles. Like, for example, pulmonary hypertension, where instead of the left ventricle looking like a donut, like a perfect circle, they may look like more oblong ovals or something like that. So it's a huge challenge to get a representative set of data to train on. And furthermore, even if we are able to get that data, there's challenge when it comes to annotations, right? So when it comes to computer vision tasks, we can simply outsource, the task of annotating these natural images to the general public, right? You don't necessarily need a doctorate degree to be able to tell what's the difference between a cat and a dog, right? Presumably. But when it comes to medical images, you need someone who's expert enough to be able to tell the difference between different structures, anatomies that we're hoping to automatically extract. And some of these anatomies become really difficult, especially like when it comes to, even with the function contouring. When you get closer to the valve planes, it becomes really tough to manually annotate these cases correctly. Now, even if we have annotations, the problem with annotations is that there's different schools of thought when it comes to annotations. And what you're seeing here is like 4 different ways of contouring a basal slice. And these inconsistencies are sometimes there purposely, right? Like, so different institutions have different philosophies on how images should be contoured and how ejection fraction should be reported subject to these contouring, right? And this not only poses a problem when it comes to training, because we have variability in the annotations, it also becomes a problem during inference, because you can imagine, depending on the standard operating procedures or the SOP at a particular institution, they may require you to output contours that conform to their SOPs, right? So for example, a center in Singapore might have a different SOP for contouring than a center in the US or in the UK. So what's the solution to that? Do we then go and train a specific neural network for each independent institution that we're selling our software to? That is really not tractable, because what happens if that SOP changes? Do we then have to get new data and retrain our networks to that? That doesn't seem feasible. So how do we solve this problem? Do we do some kind of a combination of on-site learning and domain adaptation to essentially allow the user to annotate a few cases, and for our algorithms to learn how to adapt their contouring style to what they're being shown? If we decide to go that route, we face many challenges. Like, for example, how do we overcome concept drift? How do we prevent a potentially malicious user from feeding bad contours to the network? What happens when we start overfitting to the contours that they're feeding? And if we are able to take our learning approaches and implement them on site, what benefits does that afford us? Would we be able to then do a distributed learning approach to be able to learn all the different variations in contouring and aggregate them globally somewhere to, like, share the benefits of the different contouring SOPs among the different users of the product? And if we were to do that, can we do analyses to figure out what's the best SOP, which one has the most prognostication power and things like that? And in addition to inconsistent SOPs, there are also problems that happen with missing labels. So what you're seeing here is phases in which the clinician do not segment all the three different components. I mean, if we're training a neural network to go from one image to three contours, how would we be able to use information where only one contour is segmented on this particular phase? And I mean, there's a reason why they do this. For example, you can see in this end diastolic phase, they have contoured all three. But when it comes to end systolic phase, they've indicated that the end systolic phase of the left ventricle happens at phase 12, but the end systolic phase of the right ventricle is off phase with the left ventricle, and that happens on phase 14. So this is a correct way of doing it, but however, when they decided to contour these two in order to measure ejection fraction and stroke volume, they decided that all they need is the endocardial contours for the left and right ventricle. They chose not to include the other ones. So the challenge for us is, how do we use this data? Like, can we change the loss functions? Can we change the architecture of our neural network in such a way that it can also learn from images where one or two labels are missing? How do we learn even from images that have all labels missing? Can we use semi-supervised learning techniques to actually use all of these other phases that don't get contoured to be able to learn to generalize better to the different shapes, right? Like, we always run the risk of, like, if we only train on contours that are derived from the end diastolic phase and end systolic phase, we're running the risk of overfitting to being able to contour those phases best, right? And at these two phases, the heart is more or less static, right? You think about, like, the motion of the heart representing a sinusoid, and in terms of the volume, and the volume happens to be at its peak during the end diastolic and systolic phase, but the speed at which it's contracting and expanding, it has slowed down there, so there's less motion artifacts. So all the images and phases that are happening in between, they tend to have more blurring and more motion artifacts compared to the rest. So all of these challenges are there, and these are the problems that we're dealing with on a regular basis. Now, that concludes my portion of the talk, which covered the AI tools that we have developed for CMR imaging, and essentially giving you an overview of the tools that we have successfully integrated into the product. And I would now like to hand things over to my colleague, Dr. Mohammed Omer, who's going to talk a little bit about more exciting future projects that we have coming in the line and which relate to strain imaging.
Thank you, Alborz. It's Omer here. Can you just give me the control here?
Absolutely.
Okay, so I'll be talking about the strain quantification project that we are developing for future use. Sorry, I skipped the slide. So the as Alborz mentioned earlier, that we have biomarkers, including the ejection fraction, which we use to evaluate the functionality of the left ventricle. So considering heart as a pumping mechanism to pump the oxygenated blood into the body, so the left ventricle has an important role to play, which contracts and pumps the blood out into the body. In order to evaluate the functionality of the left ventricle, we have traditional approaches, which we discussed earlier, which include the functional analysis using the ejection fraction. However, this metric is volumetric in nature, so that hinders its reproducibility in many cases. So there are quite a few different heart pathologies where which are typically identified by analyzing the reduced ejection fraction, but there are cases when the ejection fraction is preserved, but still there is an underlying heart pathology. In addition, due to the volumetric nature, it also lacks regional characterization of the left ventricle, so it's hard to locate the problem within the heart muscle. So in order to overcome these challenges, there are new strategies based on tissue tracking approach, where there are markers that are considered along the heart along the muscle of the tissue muscle of the heart, and that is tracked over the time in order to see the functionality of heart's contraction. So this includes the strain quantification methods, which allows in-depth characterization of LV left ventricular mechanics. And this allows us to gain additional prognostic information in the cases when the global parameter or global metric ejection fraction is preserved. So in terms of the cardiac magnetic resonance-based methods, there are two types of these techniques that quantifies the myocardial contraction or deformation. One method that's a gold standard or reference standard is called tagging. So on the right side, you see the tagging images, where we see that we use the magnetic labeling to form a grid in the imaging plane, and the intersection of those grid points are called tags. So what happens here is when we have formed the tag and we start to acquire the imaging sequence. So since the tissues have magnetic properties, they show the so tracking the tags is equivalent to tracking the magnetic properties of those tissues. The challenge with this approach is that it requires a dedicated sequence, which is not part of the clinical protocol, and also it requires time-consuming post-processing to gain information about tissue contraction or tissue movement. Examples of these tagging approaches are the strain encoding and the displacement encoding stimulated echoes sequences. In contrast, we can use the standard Cine CMR images and use the feature tracking algorithms to gain similar information, which is the displacement of the heart muscles, and then compute what is the heart contraction, or what are the strains on different part of the tissues. So what we do is we identify specific patterns on the given image, and those patterns are followed over time. And the advantage of this is that it does not require any dedicated sequence. So whatever is required in the CMR as part of a CMR clinical protocol, we can use it with the computer vision algorithms, which are fairly less complex. So still there are some challenges around these quantification approaches. The first thing is the lack of reference data for validation. Since the SENC, the strain encoding, and the DENS are research-based approaches, so they are not mainly used in clinics. We have a very less data, reference data to validate these recent developments of feature tracking approaches. In addition, there are multiple sources of variations, which makes these methods less standardized. So a couple of these factors include the imaging modality variations. So we have seen that different imaging modalities have different ways of collecting data. So the quality of acquisition varies. In addition, the spatial and temporal resolution also varies, which is important for tracking features. And also, the segmentation misalignment may also happen between two different modalities, so it's hard to compare the results that we get out of two different techniques. In addition to the imaging modality variations, we have a software factors as well. So when we are tracking movement, we require a lot of post-processing, including the spatial and temporal smoothing. And there are a number of ways that can differ between two different algorithms. So that is a source of variation. Similarly, we can have a different region of interest identified using different software, regional variations in tissue tracking, differences in the strain configurations, the Lagrangian versus Eulerian, which correspond to tracking the strain in a forward or the reverse directions, as well as the computation of global versus the regional or local strains. Another factor of software related is the detection of the two important phases, which may be plus or minus one or two phases in the identification. The last factor is the operator related, where the operator experience or training may come into detection of the regions of interest, which are again very important in when we are designing algorithms for feature tracking. I discussed the modality differences. So this slide shows the differences in the strain quantification when we are using different modalities. So here we are seeing 5 different modalities that are used for strain quantification, which includes the LGE, which is late gadolinium enhancement imaging, 2D speckle tracking, 2D feature tracking using CMR, tagging, and 3D speckle tracking. So on the left, we are seeing the global longitudinal strains, and then on the right, we are seeing the global circumferential strains. So if we are looking at the global values, so you can see here that 5 different modalities, the values are different, but they are still not that. The variation is still not that high. But now when we look into regional patterns, so we can see here that the patterns vary quite a bit. So that means there's a lot of variation in the intermodality quantification of the strain. Similarly here with the circumferential strain. So then we want to use some automation with the help of AI to reduce some of these factors of variations. So we have seen that operator factor is one of the variation factor. So we can get some assistance from the AI to standardize the way that the contours are annotated, the heart is annotated or contoured. And also the automatic contouring and identification of the relaxed and the stressed or contracted phases. For the software variations, we can also limit the factors of variation by using diverse data and training coming for different modalities to capture mainly the physics of the deformation and rather avoid learning the specifics of the modalities, for example, the intensities in different modalities. So these factors of variations can be, if they can be improved, then we can expect to extract the actual deformation. So the workflow that we have developed for the strain quantification is that we feed in 2 image pairs. One is the reference and the other is moving. So the objective here is that we want to deform, we want to estimate the motion that deforms the moving into reference. So for that with that motion or displacements, then we can do further processing. So first step when we have image pairs is that we need the contouring, and then AI can assist us with the annotating these two images. Then we can feed into the ML machine learning based optical flow estimation to find out what it takes in both directions X and Y to deform this image and make it into a reference image. So then that deformation is available. That flow information is available to deform the image to make the moving image into warped image that closely resembles the reference image. And again, with that flow estimated, we can put that into a strain calculators to compute strain in both radial and circumferential directions. And then further analysis or strain-based diagnosis can be performed on these numbers. So this is an example of the machine learning-based motion image registration, and then strain quantification applied on the standard CMR images. Here we can see that the radial strains are plotted on the left and circumferential strains are plotted on the right. So we can see here that as the heart contracts, there are some radial strain values on the inner walls of the myocardium. Similarly, there are some strain in circumferential directions on the right side sinus. Lastly, when I talked about the intermodality variation, so we wanted to see like the algorithms that we have developed, are they consistent across the different modalities? So in this case, we have two modalities, which is standard cine images, and the other images are the compressed sensing images that are reconstructed using undersampled case space. Again, we have two sets of data, the testing data and the retesting data, which is acquired one after the other with the few hours differences. So the objective here is that if our machine learning algorithm has learned enough information to predict the actual displacement without getting impacted by the differences of modalities or differences in the patient position or intensity information. So that is validated here, that we can see that all of this these images show similar patterns throughout the cine display of the CMR images. There are some differences in the quantified numbers where the compressed sensing images have slightly less or slightly are underestimated strain values, but those are still like being considered for further improvements. So finally, I would like to conclude with with showing our AI team that we are working together to realize these technologies for cardiac imaging. So these are all the researchers in the ML and R&D department working together to develop these technologies. Thank you, and we would be happy to answer any questions.
Sorry that the presentation went a little bit over time, but I'll be more than happy to answer any questions that you guys may have. So I see a question there in terms of why we chose CMR over other images. We didn't choose CMR over other images. As I mentioned earlier, our software actually handles both MR and CT imaging, but however, like our product has been focused mainly on CMR images, typically because of we believe that it has so much potential when it comes to assessing cardiovascular disease, just because it can image so many different important factors, like, for example, flow of blood inside the great vessels, the different types of tissue, different scarring, which is not necessarily possible with CT imaging alone. And that's why we started as a CMR company, but we do have a lot of different AI tools and features for CT imaging as well. And because of the lack of time, I kept the focus of this talk mainly on our CMR automation tools rather than explaining the tools that we also have for CT.
Alborz, there was one question. Have you explored or used active learning techniques to overcome the limited data set issue?
Yes, this is something that's under investigation right now. The challenge with active learning is that it usually requires a different level of FDA approval in order for us to be able to integrate inside a product. So there's different requirements when it comes to deploying learning techniques that are actually learning on the fly. Of course, you can appreciate that the dangers and potential issues that are involved with the techniques that are not essentially frozen, that are constantly learning. So we're in the process of experimenting with these techniques and also getting the right FDA approvals to be able to deploy such solutions. Yes.
Great. And there's a follow-up. How do you handle possible errors propagating from one level of processing to the other in a overall workflow? Yeah.
That's a really good question, and I had slides for this if we were going to talk about our CT processing. And actually I gave a talk about this during SCCT, and I think the video should be available somewhere. So when it comes to CT processing, specifically for extracting coronary arteries, we do have to break the problem down into multiple stages. And I actually advocate for the process of breaking the problem down into multiple stages. But what could potentially happen when you break down let's say the localization of coronary arteries into two stages, where you first initially do a low resolution localization and then do subsequent refinements on that, is that you do get the problem of propagation of errors. But one thing you can do is you can actually test each of these components independently and try to characterize the modes of failure. And by characterizing the modes of failures of each component, you can actually simulate these failures as an input to the next step, right? So if we can understand, like, for example, how could this first step fail, we can actually induce failures when we're training the next stage, right? So we can actually build the subsequent stage in the processing to be robust to potential erroneous outputs, right? And this is another example where we can see what happens in terms of our performance in detecting the left anterior descending coronary artery subject to different noise levels, right? That we have input into one of the stages of the process. And here we're assessing two different networks to see which one is more robust to input noise. And this is how we evaluate our steps. And another thing you should keep in mind when we're doing multi-stage processing like this is to always link the detection back to the original signal intensities. So one mistake that's common is that people apply, post-processing on the mask space alone. So to do refinement, they only pass in the prediction from the previous network. I personally believe that it's always important to maintain that connection to the original signal intensity, and this essentially allows you to keep the fidelity to the original data and also to be able to handle the noise that could be injected from the previous step.
That's great. Well, Alborz and Mohammed, thank you so much for presenting. Honestly, I've already gotten tons of texts of people really appreciating the presentation. So, yeah, thank you so much.
Of course.
All right, and thanks to everyone for joining. We've got another call here in a